The following presentation, entitled Web-Based Family History Collection and Assessment, was given by Louise Atkinson, MD, MS, on September 18, 2008, as part of the 2008 Practice-Based Research Seminar Series at Case Western Reserve University in Cleveland, Ohio.
Okay, I want to welcome everybody to week 4 of the PBRN Seminar Series. Thanks for coming back. It's good to see familiar faces. Welcome, everyone. Just want to quickly, again, bring you up to speed kind of on what we've talked about to date and where we're going tonight. In weeks 1 and 2, you may recall that we talked about what PBRNs are, what they do, why they're important, what the components are, and how they function. And then last week, Ann Reichsman from the Safety Net Provider Strategic Alliance PBRN shared with us the important steps in developing a PBRN and really gave us the history of a very successful, small, but very important PBRN right here in Cleveland that's done really good work with safety net providers and patients. And then we also discussed how generalizable PBRN research findings are to non-PBRN practices, a really important methodological issue in practice-based research. Tonight, what we're going to do is we have with us Dr. Louise Atkinson of the Case Department of Family Medicine. She's going to talk with us about internet-based data collection and assessment tools in PBRN research, specifically with application to family history, gathering family history information. Talk about the acceptability of these tools, how they might potentially interface with electronic health records, and then evidence gaps in family history information. Also tonight, I will share with you after her presentation about data collection methods in PBRN research more generally, other types of electronic methods and card study methods for PBRN research. Before I begin, Kurt Stange is going to follow up with us about what we discussed last week about the National Ambulatory Medical Care Survey and how that tool can be used in some creative ways. So I'll pass this over to Kurt, and then he will introduce our speaker for this evening.
Thanks, Jim. This is kind of a bridging topic between last week and this week. Jim told you last week about how networks have used the National Ambulatory Medical Care Survey to show the representativeness of their networks. And you do that either to show that you are nationally representative or to show that you're different in unique ways. For example, Ann Reichsman's Safety Net Network is different in ways that are actually the focus of the network. They serve a population of people that would otherwise be underserved, so they're different in a good way. What I want to mention as part of the theme tonight about PBRN research and data collection methods is how you might use that same method in a way to particularly launch a network. So if you're a network director or the director of a new network, I'm looking at Carl Tyler, who's getting ready to launch a new network here. One of the things you might like to do is set up future grant applications and things by showing how representative the patients seen in your network are. But if you're trying to, as you're starting a new network, you're also trying to get clinicians engaged, have ideas that people have in practice, be part of some of your first studies. And frankly, a representativeness study is kind of a yawner. I mean, it's not a really exciting way to start. But one idea that a number of networks have used is to combine those two things. So as to decide they're going to do the NAMC study, have clinicians in the network collect de-identified data on a consecutive sample of patients. And there's some advantage to that for the network clinicians. They get to characterize their practice compared to a national sample. They get to see how they're doing compared to other clinicians in the network. And if you're in practice, you're kind of isolated from other people. You kind of like to know what other people like you are doing. So it meets a network development need in letting people characterize their practices compared to others. Meets a network need of characterizing the practice, or at least the patients seen in the practice, that you will use in future grant applications. But it doesn't meet the need of having clinician-initiated questions. And what some networks have done is surveyed the network clinicians or gotten the steering committee early on to say, what are some of the areas we're interested in? What are some of the questions we're interested in? And some of those, they just kind of park on the side and say, well, this is something we need more development. Let's get some groups working on this. Some questions they might park and say, well, we need grant funding for this. Let's really look at that. But there might be a few questions, or often are a few questions there, that you could tack on to the NAMC's data collection method. And I'll just give you 2 examples of that. Sharon Wire, who's an advanced practice nurse, a doctorate prepared nurse here in Cleveland, is starting a network of nurse practitioners in Northeast Ohio. And she is going to have the nurse practitioners do the NAMSES method to characterize the practice. And when she had her first steering committee meeting, and did her first survey of the network, one of the burning questions was to really characterize how nurse practitioners practice in ways that are different from physician practice. And so just doing the NAMSES helps to answer that question. But she's also then adding on a few other things. She's adding on some nursing diagnoses that will be specific to that practice and help them to characterize some unique things about the nurse practitioner approach to practice. So she's meeting a bunch of aims with using that data collection method. The Kentucky Ambulatory Network did a similar thing. They did the NAMSES study for their first study, and they had a large group that was interested in obesity, and so they decided they were going to collect body mass indexes on all the patients that they saw. And by itself, that's not worth much, but if you look at the NAMSES form, which was in your handout, if you characterize patients seen by body mass index, you can look at, well, what are we doing? Are we doing more diet and physical activity counseling, for example? So they did that as a way of getting pilot data for some future studies they might want to do on obesity. So it's just something to think about, particularly if you're starting a new network. It's a data collection technique that you can use. You can have the clinicians of the network use the NAMSES form, and you can meet a number of aims. And later, Jim's going to talk about the CARD study, which is really the quintessential method. But next, Louise Atchison is going to talk about some electronic data collection methods and some interesting work that she's done. Louise has experience as a practicing clinician in Seattle, Washington, in full-time practice, started a birthing center there, came here to do a research fellowship, did some work with the Amish, did some epidemiological research with the Amish. She just told me she was actually out at the birthing center, and she's been working with the Amish Birthing Center for a while. But the research she's going to tell us about really started in a fellowship she did to really focus her interest and expertise on clinical genetics and how that might be applicable in primary care practice, and she'll tell us about some data collection methods for a network study that she did here in Cleveland and actually with the National Family Practice Network.
Thank you for having me speak, and please, I guess, interrupt if you want to. I wasn't sure if you would be more interested in the family history aspect or the online data collection aspect, but I think I'm probably going to focus against the grain for me on the online data collection aspect. And so I have an outline there, and we'll just keep going. But just a little bit, we focused almost from the start on computerized methods of collecting family history, and I wanted to tell you a little bit about why, so that you'd get the background of why we did the studies that I'm going to describe. And first of all, the issue was feasibility. During a regular visit with a clinician, except if it's a genetic counseling visit, there's usually not enough time to collect a very detailed family medical history. Many practices resort to using a form that patients fill out, and we heard in our research that patients don't like to have to do that every time they go to a new doctor, and eventually could be interchangeable. You can see that some of the data from Kurt's DOPC study showed that the average discussion of family history in a medical visit with family doctors was 2 minutes, if it was discussed. And that slide also showed that about 40% of patients' charts had in it something about the family history of, for example, breast cancer. Usually just a yes, no, and that's really all right. So these are actual data from the study I'm about to describe, where healthy people in family practices and primary care practices recorded their more detailed family history of several common diseases. And for about 40 or 50% of healthy people, they don't have any relatives with, say, cancer, the common types of cancer. And so if you ask a yes or no question, you're done. But there's another half, or maybe 60% of the people in primary care who actually do have some family history, and then it may be necessary to go into more detail. For example, we've now got this U.S. Preventive Service Task Force recommendation that people whose family histories show increased risk of a hereditary breast and ovarian cancer ought to have something more done to delineate their risk and perhaps do extra preventive measures. So to recognize that type of a hereditary cancer pattern, which will be present in maybe 1 out of 200 of your unselected general population patients, you need a more detailed family history. than you can get just by asking a yes/no question. So that was the rationale. And there are plenty of data from many descriptive studies showing that the type of family history you need for good, for example, cancer risk assessment, doesn't exist in medical records and isn't used systematically. Second thing, we're interested in the online and computerized tools because they lend themselves so well to automating the assessment of the family history to some extent and including decision support. And so you could prompt something to be done on the basis of the family history and give those prompts either to the patient or to the clinician or both. And you could build in assessment of the family history and risk of disease, which we've tried to do with a tool that we've developed here for cancer risk assessment. And finally, it's a fertile field for research because there's a big evidence gap about if you had the ability to do systematic family history taking, how would it be useful and how would it benefit patients and clinicians. So, for example, AHRQ just commissioned a systematic review of the evidence about using family history of cancer for preventive care, specifically focusing on family history tools that could be used for assessment. And they looked at 3 topics, which are listed here, found that, yes, people really do know their family history of cancer, at least in close relatives, well enough to be useful and can report it fairly accurately. They have data on sensitivity and specificity of family history from several studies. Then they looked at family history tools and evaluated 18 different tools that they found in the literature, both paper and computerized. And their conclusion was there is evidence that self-administered family history tools outside of an interview with a clinician perform well and are likely to improve on clinical practice because clinical practice just isn't, very extensive. But when they came to evaluating the effectiveness of risk assessment tools for promoting clinical actions that would be recommended based on family history, they found a paucity of evidence and found that only 3 of these tools, 18 that they found in the literature, had been evaluated in controlled trials, and knew that another tool, the CDC's Family Healthware tool, was in the process of a clinical trial. What they also found was that risk assessment tools that clinicians had to use, the clinician had to take the family history and put it into a tool, they didn't use it. That's not a surprise to me. If they did, one study showed that it did increase the appropriateness of referrals for genetic consultation, which is a small subset of our patients. And if they were designed for lay people to use, there's a couple of problems here. One is that you have to pay people to use them in some studies, and uptake is generally only a subset of people who are offered the tool. For example, I'll show you that we had an overall uptake of 16% in our study of the CDC's tool. The preliminary evidence is if you make it part of clinical care where the person has to come in and record their family history before they get whatever service it is they're coming for, and the staff all know that and they use it then in the clinical encounter, and it's efficiently done, then thousands of people will use it. For example, in a study of using family history risk assessment at the time of mammography that has been published. So AHRQ concluded there was insufficient evidence yet to know. So we're glad to be studying this. And now I'm going to show you just a couple of examples. This is the CDC's Family Healthware tool. It's online. You need an access code currently to get to it. And it records not only the family history, but also the person's lifestyle risk factors for some common diseases in rudimentary form at least, and the use of screening tests for these diseases so that it can calculate whether the person is eligible for certain screening tests, both based on their family history and their past history of screening. And it can give personalized messages that take that into account. They say, you had your colonoscopy, keep up the good work, get one in 10 years. Or they can say, you're due for blood glucose screening based on your family history. The nice thing about all these is that the person may need to go through a lot of work to do it, but immediately up on the screen they get their report. And we think that's a draw. I have the Surgeon General's Family History Tool listed here because it's available to you right now. You can go to the web, try it out, and National Human Genome Research Institute and other parts of NIH are busy right now reprogramming it. So that there will be a database attached to it and you can save things in aggregate form, which was a major obstacle for being able to use this for research. And B, so that the output will be compatible with electronic medical records by virtue of being in a standardized data format that has recently been adopted by informatics societies. And it's also available in Spanish, and they're going to put it in the VA's medical records starting in November, supposedly. Our tool is specifically designed for assessment of cancer risk, and it is online at a secure site here at CASE. So those are the CDC and this great system are the two that we've been testing. This one gives a personal report in the form of a PDF file with a family tree and an interpretation of hereditary or familial as well as personal risk of breast and colon cancer, and no other cancer risk assessment at the moment. What do I mean by it connects with CancerGene to give more information about cancer risk? This is an online program that if you go online, you have to fill out the family history. It's meant for clinicians, so it's time consuming. But if we get the patient to fill this questionnaire out about their family medical history, then in the background the computer can connect to this software, and it can give the Gale and Klaus model risks of the person getting breast cancer in the next 5 years or in a lifetime compared to the general population, and it can give a probability of a mutation in BRCA1 or 2 based on their family history data. We don't show that to the patients, but we use it as a basis for our messages, and if you were an expert clinician, you could get the actual table like that. So that's just an example of a family tree that it would create based on the questionnaire on the web. And then I just want to mention that based on input from lay people, and even on some data that we have from our studies, our qualitative studies, there are people who don't want a website to tell them about their family history, but they would like a social networking approach. And they want to go out and invite their friends and family to put in their family history and something about their personal life. So the Genetic Alliance, which is a self-help organization for people with genetic disorders, went ahead and created a customizable online kit for communities that they could use to collect whatever that community wants to. It could be a family, or it could be a group of people with a certain disease, or it could be Hispanic people in San Antonio, or whatever. They can customize the family history collection so that they can include stories, pictures, all sorts of things. It's not designed as a database for research, but it's another approach to collecting family history. There's a prospect of having genealogies be able to use that approach too. Many genealogy sites now have a social networking web function to them, and genealogists for the last 10 years have been experimenting with GEDCOM, which is a standardized file format for exchanging family history data and connecting families with each other who are related. So obviously, one of the big critiques of doing a study by having people go online and fill out a questionnaire is it selects for people who use the internet, who have a computer maybe at home, and who are comfortable online. And I'm sure that's absolutely true. To what extent does it select against old people? Well, your basic source of information if you're planning a study might be, for example, the Pew Foundation's internet use surveys that come out every year or two. And they tell population trends based on national representative data about use of the internet. So you could get information about that. These are some quotes from physicians who are in our study of the CDC's tool. And they made comments about how elderly patients often are interested in using the internet, especially for email. And many have time to go ahead and go online and do our family history. A rural physician commented that he was continually surprised that so many of his patients were connected to the internet, even though they had to use satellite dishes. And in the inner city practices, the issue definitely was lack of computer access. So a cautionary note is that we had one practice in our CDC study where we gave every practice a computer and told the participants who were patients in the practice that if they wanted to, they could go to their doctor's office and use the family history tool there. And virtually no one did except in one practice, which was in a migrant worker population in a city in the South. And there, that was the only way. The majority of people in that practice who participated in our study did it at the doctor's office. And when we went to follow them up, the people that we contacted said that was the only way they could do it, would be to go back to the doctor's office. And they were afraid they'd have to pay for a visit if they did. We had a very large drop-off in terms of being able to follow up with those people. So that was one of the lessons I learned.